problems with the vascular system tonight on Call. Funding for On Call television is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call television as it continues to open doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Dakota Care, the Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, Dakota Dermatology, Aberdeen Asthma and Allergy, the Orthopedic Institute, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation. Vascular disease affects your circulatory system, ranging from diseases of your arteries, veins, and lymph vessels to blood disorders that affect circulation. We'll talk about how it works and what happens when it falters when the doctors are on call tonight.
You done stomped on my heart and you mashed that sucker flag. You just sorta stomped on my aorta.
Hello and welcome to On Call Television. Tonight we'll be discussing vascular disease. There are three types of blood vessels in our bodies which allow for circulation: arteries, which carry blood from the heart out to the cells of the body; veins, which return blood directly back to the heart; and lymphatic vessels, which carry clear plasma fluid passively back to the heart. An expert in all of these vascular vessels is with us tonight, Dr. Mike Bacharach. Welcome, Mike.
Thanks, Rick. Thanks for having me here.
So you're at North Central Heart in Sioux Falls, and you've been here for how long?
19 years.
19 years. But now you're originally from?
Well, I grew up in western Wisconsin, and then went to the University of Wisconsin and trained at the Mayo Clinic, and then subsequently I spent some time in the Cleveland Clinic on staff there, and then I came to South Dakota in 1995.
But see, you're not just a cardiologist, you're an interventional cardiologist that works a lot with vascular. Well, tell us about that.
Yeah, so my area, I was exposed already at the Mayo Clinic to a number of people that were really specialists in vascular disease or vascular medicine. And so as a subspecialty within cardiology, I chose that. And so I did become an interventionalist, but I take care of lots of medical vascular problems as well as interventional ones with balloons and stents and those types of things.
You're sort of the cross between the internist, like I am, and that advanced into an area of surgical intervention. So you're kind of a half surgeon, half internist.
Well, that's right, and there is a lot of cross-reactivity with vascular surgery as they've moved into the area of what we call endovascular surgery, which is the balloon-type procedures rather than open operations. And so there is a lot of similarity between what we do.
So a lot of cardiologists do angioplasty and stent placement in the heart arteries, but you've been involved with placing stents and doing that kind of endovascular stuff, as you say, all over the body.
Right, so yeah, so my area of interest and expertise really is in not so much in the coronary arteries, but in the blood vessels that go to the kidneys, blood vessels that go to the legs, the large aorta that can develop aneurysms, and also the carotid arteries, which provide blood flow to the brain, and when they become blocked can cause a stroke.
Right. So those are your territories. What was it that you thought you'd be doing mostly when you started, the carotids?
No, I think that most of the early work actually in peripheral vascular really had to do with the legs. Patients who had sores on their feet that wouldn't heal,
yeah. Right.
Diabetic patients, or patients who had what we call claudication, which is leg distress or discomfort when they walk. And so...
Sort of angina of the legs.
That's right.
You know, you get aching pain, you stop, it catches back
And so for many people, it became very lifestyle limiting. They couldn't do their work, or they couldn't enjoy themselves in a way. Hard to walk 18 holes on the golf course if you can't walk.
Right.
So that was really, I think, what I was initially exposed to, and it evolved then to involve other things, including the veins and to some extent lymphatics, but not quite as much.
When I was I was a nurse's aide at Swedish Hospital in 1969, and the first thing that I ever was able to watch, I asked if I could watch a surgery. I'd never seen a surgery, and I'm this nurse's aide guy, you know, this orderly, and they said, fem-pop bypass, we'll have you watch. It's a long, kind of a boring surgery. And I watched the whole thing, beginning to end. Now, what you did is like a fem-pop bypass, but only not so complicated.
Well, what's happened over time, when I first was in training, surgery was the primary kind of treatment for patients who had blockage in the leg blood vessels.
And that's what a fem-pop bypass is.
Right, going from the femoral to the popliteal, just above the knee. What then happened was there was a development of lots of technology that involved balloon angioplasty, stents, atherectomy devices, which are devices that can actually clean out some of the plaque material. And as they evolved, they have supplanted typical open surgery, not completely, but certainly it's much more common now to fix those arteries, those blockages, with balloons or stents in a less invasive way than doing it with an open operation.
Wow, I mean, huge difference. So since you've been doing this, you're still involved with teaching. Who do you teach?
Well, I do have an appointment. I'm very proud of it at the university, at the medical school. We certainly have residents and students who come through. We are also part of the fellowship program at the Mayo Clinic. So the vascular surgery fellows, their first and second year, after they've done their general surgery training and now they're doing their specialty training in vascular, come and spend 3 months with myself and Dr. Reynolds.
So you have, you're training the Mayo Clinic surgeons.
Yeah, so.
That's pretty neat.
No,
that's really neat.
Actually, it's been great fun. We've been doing it now 7 or 8 years, and it works both ways. I learn a great deal from them, and hopefully they learn something from me, and it really is a nice, as you know, it's really, that's important about interchange and the educational process.
When I have an opportunity to teach, and I love to do that, it's a win-win for me, no question.
Yeah.
Well, On-Call Television is your show, and it's better when you participate. We invite you to call in your questions at 1-888-376-6225, 1-888-376-6225, or visit us at oncalltelevision.com and click on the Email a Question button. We need your questions. That's what makes this better. So, and you have also been involved with the national organization. Tell me a little bit about that.
Well, I became very involved with the Society of Vascular Medicine, which is the national organization for vascular medicine specialists, and over a number of years, and I am a past president of that society. So I have been involved in, we have some certification examinations, teaching materials, that sort of thing. That
writing questions.
That's exactly right. So fortunately, I've been involved, and that's been actually great fun. And it's kept me in touch with many of my former colleagues, people nationally. It's also forced me to go to many of the meetings and kind of keep me abreast of what's going on in vascular, which has, again, been, I feel very blessed about it.
So one of the things that's happened in the last maybe 10 years has to do with realizing that aortic aneurysm, abdominal aortic aneurysms, might be something that we would screen for which we should screen. And then they've said, well, cost effective, it's men, ages from...
Yeah, 65, and who smoked.
And who smoked.
Right.
So tell us about that.
Well, you know, that's a controversial issue, and each of the societies, the Society of Vascular Medicine, the surgical societies, the cardiovascular societies, all have had input, and ultimately it does come down to some extent to economics. What you have to recognize is that many patients presented with a sudden rupture of that aneurysm. There was no one had any idea they had it, and of course when they come in extremis, it's a catastrophic event, and many of those patients unfortunately didn't survive. So it became important, and I think certainly a target for many of the vascular societies and people who look after patients with vascular disease to try and improve screening. Ultimately, that the economic realities of that you have to screen large groups of patients to find a few, but for every one that you find that you prevent a sudden death or you're able to fix it before they come in with a catastrophic event is huge, both for the patient and also for our healthcare system. So it's been, so there's still some controversy. Clearly, if you have a family history of aneurysmal disease in your parents or a sibling, if you're a smoker and you have higher risk of cardiovascular disease process or you've had previous cardiac disease, then it's probably best to get screened.
Let's go to the telestrator and draw on this. Tell us what this is about. This is the abdominal?
Yeah, so what you see here, this is the normal aorta, and then as you can see here, what's happened is this has widened out across here and bulged so that you have this large bulge of the aorta, and that's weakening or outpouching of that aortic wall, much like the old bicycle tires, that develop a sidewall. And of course, the wall tension increases, and so there's a greater risk that these can break. And again, if they rupture and break, it's a catastrophic event.
So there's a size that we decide that we're going to go to an intervention?
So yes, there's a fair amount of epidemiologic information and a variety of studies, but I think the consensus is that once it gets to be 5 to 5.5 centimeters, the risk of rupture exceeds the risk of an operation or of repair. And those patients clearly should be fixed. Smaller aneurysms are more challenging, and there are a few that probably warrant repair, but by and large, that 5 to 5.5 centimeters is kind of the threshold.
Right, the threshold. The risks are in the 5% per year range at that point, right?
Right. Yeah, some are actually perhaps even as high as 10, and as they get bigger, that risk increases.
Right. Show us what you would do. Let's change this to red. What would you do? I mean, the old way. You would open up the abdomen and
cut. So yeah. So what you would normally in the old days, what you'd do is you'd open up. You'd make an incision here. You'd sew in a graft and bring it down, something like this. And you'd sew that in place, and then you'd take this old aneurysm sac and wrap it around there. Nowadays...
Okay, let's erase it right there. Touch that.
Oh. Nowadays, we can often just line it with a new tube, something like this. Okay, and this is a stent. And that way you don't have to make an incision in the groin, but you can make an abdominal incision. You can make a small incision in the groin and pass this up from each side and do it that way. It's much less invasive, and the advantage is that patients often are in the hospital only for a day or two.
Yeah.
They can go back to work within a few weeks.
Wow. Because that other surgery was so big time. I mean, it was like 20 to 50% mortality rate or some...
Well, it got, in the early days, it did get much better than that, but it was still not uncommon to have 5 to 8% mortality, even in relatively healthy patients, and they often were in the ICU for weeks at a time. So you're right, it's much less invasive now.
And that's this question first, is surgery for an aneurysm a high-risk procedure? And so if you do it with your way, there's a risk. What is the risk?
Yeah, it's a good question. With an open aneurysm, and there are still patients who require open aneurysm repair, and what's called an aneurysmectomy. That risk in someone who's of reasonable health is somewhere in that 2 to 5% range of having a major event or not surviving the operation. With endografts, where I drew earlier, right, where you slide it up, the risk there really is very low. It's not 0, but it's probably in that neighborhood of 1 to 1.5% of having a major complication, and rarely does anyone die from it. Certainly if you plan it out well, there's really no reason for them to die.
I have a dear friend, patient, who's not going to be able to do the endografts because of the calcification in the femoral arteries and the challenges there. So that's a difficult, more challenging scenario.
Right. Although the technology continues to improve, and we have smaller devices. We have devices now that are called fenestrated devices that allow for preserving branches that we didn't used to be able to. So that technology, you know, you may have to relook at that and see whether there's another alternative.
Okay. Here's from Viberg. Explain the term hardening of the arteries, and what does it mean, and is it dangerous?
Well, hardening of the arteries is a sort of a lay term for atherosclerosis. And the reason it was noted you know, by the early doctors and pathologists that the arteries were very hard and calcified. And what happens is in the healing process, there's this thing we call dystrophic calcification. So the area of the artery becomes very hard, and often calcified. But that's really not the primary issue. It's the plaque and lipid cholesterol material that builds up on the inside, that then the artery gradually becomes degenerative, and then the body tries to heal it by making it hard. And so that's where that expression comes from.
Right.
And generally it is bad. Unfortunately, and that's a really nice picture of it. You can see here this plaque building up on the inside, on both sides, and causing obstruction of the lumen, or the inside portion of the blood vessel. So it is bad, but you know, to some extent we all have it, and we will get it. Obviously, the things you try and do to prevent it from getting worse.
Well, some say it's a aging process. No matter what you do, these will occur. But if we have premature aging from diabetes or hypertension or all these things, we can maybe slow it down or prevent it from happening so quickly.
Right, and I think the argument, though, is that there are certain cultures and societies that have much less of it, despite the fact that they're getting old. So I'm not sure it's just aging. Certainly that's a big part of it. In Western countries, and certainly in our diet, especially in the past, with high tobacco use, high-fat diets, you know, the fast food types things, we accelerated that process. So I think we have a much greater extent of it than some of the other cultures that perhaps are more prudent.
Prudent.
Yeah.
A prudent culture.
Yeah.
The National Institutes of Health say that 1 in every 20 Americans over age 50 has peripheral artery disease, or PAD, and 1 in 3 over age 70 have it. Fatty plaque builds up in the arteries and often affects the legs. This potentially deadly affliction can be treated and controlled in a cooperative patient.
I was a very stressed out, overworked salesman, and I came down with a huge pain in my leg. Yeah, I was traveling home and I ignored it, and I think it came down on a Thursday, and I lived the weekend on the couch moaning and groaning and popping ibuprofen. And finally had my sons take me out to the clinic to see Dr. Rick Holm on Monday morning. He could tell exactly what it was because of the numbness and the whiteness and the coldness of the leg. And Dr. Holm told me in about 5 minutes in his office that he needed to get me to the heart clinic in Sioux Falls immediately. What they did was break up the clot, but then they took a piece, and I'll say vein, although I don't know if that's the correct term, and they borrowed one from up here on the leg, and they put it in down here on the leg, which evidently was a remarkable feat of surgery. I know, I certainly felt a lot better. I was a smoker, am a smoker. No, I did not have problems with cholesterol. I had, at that time I had had 2 heart attacks that I had angioplasty done for down at the Heart Institute. Not a very good diet, about 60 pounds heavier than I am today. Very, very little attempt to exercise other than walking through airport concourses. I'm a diabetic also. Because of all of the good things, including the weight loss, my medications have dropped drastically. I still take insulin, but the number of prescription drugs have gone from about 12 or 13 a day down to 3 plus the insulin now. Life in general, watch the diet. It doesn't get easier to lose weight and become healthful or semi-healthful as you get older. Yeah.
Thank you for doing that, Mike. And you know his story. Did you see he lost this weight? He's trying to exercise regularly. His diabetes is much better controlled. He still struggles with those cigarettes, but he has done extremely well in recent years. And I think the stress in his life is greatly reduced, and that's made a lot of difference. You talked about an aneurysm in his leg.
Yeah. So actually, he had a less frequent problem in which we talked earlier about aneurysms of the aorta, which is certainly one of the most common locations. But you can have them in the artery behind the knee. And when that occurs, that's called a popliteal aneurysm. And they tend not to rupture, but what they do is they block off and then they send little plaque down. So that's what happened with his. His actually blocked off entirely, so suddenly his leg was threatened. And so we used some blood clot dissolving medicine, got that open, and then of course we're left with the aneurysm. So in that setting, surgical repair where you do a bypass and then basically take that aneurysmal segment out of the circulation is the treatment. And so that's what he had done.
That's what he had done. So, join our conversation and call in your questions or comments on tonight's topic. Call 1-888-376-6225, or you can email them to questions@oncalltelevision.com. So we have a couple more questions. Here's one from Burke. Aortic stenosis, how is it fixed? What do docs do for this? Now, it leads to the question of calcific aortic stenosis, probably what we're talking here. And you alluded to calcification in the arteries, and you said that's not the problem. It's the progression of the collection and other things that often is the major problem. What about calcification? And then we'll talk about aortic stenosis.
Yeah, so in a generic way, you need to understand that calcification is often the way the body tries to heal things. So again, that's the fancy term for that is dystrophic calcification because it's not normal, it's not healthy. So valvular heart disease is a little different than hardening of the arteries. And it may well be that you have a genetic predisposition to it. There may be that you have, for example, a valve that's a bicuspid valve as opposed to having 3 leaflets, it only has 2, something you were born with. Those patients are at higher risk for having aortic narrowing or aortic stenosis. So the caller's referring, I presume, to aortic stenosis of the valve. Now you can have narrowings of the aorta as well, and you know, in that setting, so that's a little different. That's just the same kind of narrowing you get in the leg, but it involves the large artery through the abdomen, and you can imagine that will affect both legs and often can be very significantly limiting. So, but the valve issue is a separate sort of thing. Now, and with that regard, typically, you know, it was a surgical operation. Nowadays, we have this transaortic valve replacement, which can be done through a small incision in the groin. So there are some other opportunities too. Technology is evolving there as well.
Right, but is it ready for prime time? You know, I saw a presentation about aortic stenosis and the you know, doing it through the femoral artery, right, and just like your procedure instead of cracking open the chest. But the risks of stroke was so significant early on.
Actually, the devices have gotten better. I think that the patient selection is better. Actually, both of the systems, both the Avera system and the Sanford system, have teams now that do it routinely. So again, in select patients, the recent data that just came out from the American College of Cardiology suggested for the first time that one of the new devices that's made by Medtronic actually was superior to open operation in that higher risk population. So we'll see where this goes. There's clearly a lot of investigation that needs to be done, but we basically have 2 commercially available devices now nationally. So it's it's moving forward at a very rapid pace.
Right, and you said select patients. In other words, you're thinking the higher risk patient should be the one getting this method.
That's right, and most of the investigation has actually been done in these patients who were thought to be
not
good surgical candidates. Now, if you're very, very high risk, then it may not be a good option for you either. But certainly many of the patients who we all know, we have patients who are, they're in their 80s perhaps, they're functional, they're still living independently, they're looking after a spouse, and they need to continue to do that. But to try to put them through an open operation is, it's unlikely that they'll ever get back to the same level of functioning. They may spend time in a nursing home, you know, the issue of quality of life. So for those subsets of patients, this is clearly a wonderful technology.
High risk in this case would be elderly,
primarily
lung disease,
right.
Maybe, those kinds of things.
Or patients who've had previous operations, because anytime you have to redo an operation, it's
right.
more complicated.
All right. Here is a call from Madison. 71-year-old caller has cardiomyopathy for which he takes medicines. How does this affect life expectancy? Cardiomyopathy, now that's the heart, that's what you deal with. Cardiomyopathy meaning weak heart muscle. How does that affect life expectancy or other problems?
Well, without more information, that's a difficult question to answer. Certainly, cardiomyopathy is a generic term implying that the heart muscle is not pumping well. Now, some patients actually do pretty well, and with medications, they can live quite a long time and they can enjoy a very good quality of life. For others, where the heart function is very diminished, they tend to develop fluid in the lungs, they get what we call congestive heart failure, they have significant decreased exercise tolerance, and their quality of life is very diminished. So, and unfortunately, there is premature death associated with those. So it's hard to know, and again, what you of course want to see your doctor. You want to make certain that you have all the treatment available. You know, nowadays we have implantable defibrillators and biventricular devices, and lots of really great technology as well as great medicines to help those patients. Ultimately, the best option is, if it's due to blockage in the heart arteries, the best option is not to get the blockage in the heart arteries first off. So.
Let's go on. But I think I would emphasize just exactly what you said, and that is that it is like saying they have an illness of the heart. It is so broad, and there's so many different things that could be a part of it. And if age is an issue, what is the cause of the weakness of the heart? You know, and so many variabilities. Right. So people who hear this need to realize every case is so different. You've got to lean on your primary care doc and your cardiologist, and in that one. Here's from Sioux Falls. Caller has macular degeneration. Is there anything people can do in the vascular system to lower the blood pressure in the eye or to help macular degeneration? And does that have anything to do with macular degeneration?
Well, you know, I'll be the first to admit that I'm really not qualified to answer that. I don't know. I would advise that patient to see their ophthalmologist and talk with them. I know that there are a couple of different types of macular degeneration, and there are some treatment modalities for that, but that's unrelated to what we call systemic blood pressure, or the kind of garden variety of essential hypertension that we know causes strokes and contributes to heart disease, and what I'm concerned about from kidney function and so on.
Right.
So it's a little different, but again, I'm not an expert in that area, so I really don't want to go out on a limb and say something wrong.
Okay. Well, we can talk about hypertension because that is your bailiwick, and hypertension is a big part of all this. Although I know that hypertension, the treatment of hypertension is on the move right now, because we're realizing we've got people too low and they're passing out and breaking hips on their way to the bathroom and so on and so forth. And now I've recently read 130 to 140 is the right systolic pressure to go for, particularly in the elderly, and maybe even 150. What's your comment about hypertension and what it does to vascular disease, and what is your target?
Yeah. So, you know, hypertension is a concern, and it's one of the difficulties about treating patients with high blood pressure is the fact that they don't feel bad. You know, they often feel fine, they can do their activities, they get along well.
Until we give them medicine for it.
Well, that's true. So But what happens is it sneaks up on them insidiously. Suddenly their kidneys don't work right, or they've had a stroke now, or it contributes to their heart disease. So it's really very important to treat blood pressure. It's not okay to benign neglect and just pretend you don't have it or say it's borderline. So, so hypertension really brings out often the clinical manifestations of this hardening of the arteries and these other problems that if you control the blood pressure, for some of these events wouldn't happen. 7-fold increased risk of stroke, increased risk of kidney failure. All of this is attributable to high blood pressure. When you say it's on the move, there's no question we have better medications now than we've ever had. We're learning more about using combinations of medications, the angiotensin receptor blockers along with a little bit of diuretic, or combination. Well, really in the right place. But the combination of medicines, so you get a synergistic effect and perhaps can keep the dose down a little bit. We're still having problems with the very difficult hypertensives, the ones that are very hard to control and require 3 and 4 medications. That's the group that you referred to. They don't feel well. They don't sleep well. They have, they end up urinating a lot. They have lots of side effects from their medication. One of the things that's been looked at now is this renal denervation technique, where you go in and actually use a electrode to denervate the nerves that provide the kidney. The initial trials were very promising. We thought this was going to be wonderful. A large randomized trial was just published or brought out now at the ACC meeting, suggested maybe it's not quite as good as we thought. It's safe, but it didn't have as much of an effect as we wanted it to have. But there's a number of other companies that are going ahead, and we think that this may still be a very important modality of treatment for those patients who are on multiple medications, not the person who's on one medication.
So in the artery, you go in and you burn the nerve that's connected to the renal kidney artery.
That's right.
Is the controller of blood pressure.
That's the controller of blood pressure, that's right.
Carotid arteries, we haven't discussed that yet, and I want to touch that. A lot of people talk about these screening ultrasound groups come in and they say, we can screen your carotids, we can screen your aorta, we can screen your legs with an ultrasound system. And my general rule is, if they can do the aorta, and you've been a smoker and you're in the 60s and there's family history, by golly, do it, because it's pretty cheap, and if it gives you a clue of an aortic dilation, that's appropriate. But it's kind of hard to interpret their carotids and their lower leg artery. Tell me what you think about those.
Well, so the carotid is a vessel that's often affected by atherosclerosis. It's serious because when it does become narrowed, it can lead to a stroke. And it's a surface vessel. It's close to the surface, so you can actually visualize it very well. The abdomen in some of our better nourished patients can be very difficult to see. So the neck is kind of a window to determining whether there's atherosclerosis. It's also a marker, so that if you have blockage there, you may very well have it somewhere else. So the issue of carotid screening, again, is an economic one. If you, as the physician, hear a bruit, our general teaching was that you should do an ultrasound and look at it. We know that bruits are more common in the elderly. If you're more middle-aged and you have a bruit, you should for certain have an ultrasound. Actually, there's some newer recommendations now that you shouldn't routinely do it. So I know it's
a moving target.
Right, it is a moving target. But my own personal sense is, certainly if you hear a noise, if your physician hears a noise there, you should get at least a baseline screening ultrasound. Some of these screening things that are done are really very good, as long as you don't make the full diagnosis. You often have to refer them to an accredited lab who's going to do a more complete test.
So not a bad deal for a screen.
Right, not a bad deal.
All right. Are you worth your salt? This oldest of spices, once used as a measure of a person's abilities, makes our food taste better, but can, if overdone, be a recipe for significant health problems.
Cutting back on the sodium in your diet can seem to be quite a task, but really can be quite easy. It is recommended to consume about 1 teaspoon of salt a day, which would be about 2,400 milligrams of sodium. To work on cutting back on the sodium in your diet, start by reading the labels on the packages of the foods that you eat. Look under the sodium content, and then also look at the serving size of the food that you're eating. Next, when you're shopping at the grocery store, shop the whole foods section, the fruits, the vegetables, the fresh meats, and the dairy products. The foods in the center of the grocery store are prepackaged and sometimes processed. They often are going to be higher in sodium. When looking at fruits and vegetables, if they're not fresh, try to choose frozen instead of canned. Typically, the sodium level is going to be less. In cooking and seasoning your foods, try to use fresh herbs and spices or dried herbs and spices to season your foods instead of salt. You also can use strong flavored vegetables such as onions, peppers, and garlic in your cooking to really enhance the flavor of your food. Cutting back on the salt in your diet can help you manage a disease such as high blood pressure or kidney disease, but also can help you really enjoy the flavor of the foods that you're eating.
There's still time to call in your questions about vascular disease. Our number is 1-888-376-6225, or email us your questions on oncalltelevision.com. So salt, I know there's a lot of debate about salt. I have my own opinions. What's your take on the danger of salt?
Well, you know, salt is it's one of those things that clearly has a significant impact, especially on patients who have heart failure, decreased heart function.
That cardiomyopathy
That's
thing
right.
you're talking about.
Patients who have hypertension or blood pressure problems that are difficult to control. Again, you recognize that water follows salt, so you tend to retain fluid when you take a lot of salt in. You know, and I like pretzels as much as the next guy, so I think in moderation it's okay, but again, you need to recognize, especially if you fall into one of those special categories, that reduction of salt is important. And I think the big issue is that there's so much hidden salt in things. We often are not aware of how much sodium there is in things that we're eating.
Well, and of course, if you're exercising regularly, you lose a lot of salt too. And I have to say that the data on hypertension being salt responsive, it's about half of them. The numbers say that if you cut out the salt in the hypertensive, half of them blood pressure would lower, and the other half, it had nothing to do with the salt. I mean, would you agree with that?
Well, I think so, and I remember my father, when he first was diagnosed with hypertension, and he thought that by limiting his salt, he wouldn't have to take his medication. Yeah. And that clearly was not the case. He needed to take the medicine. So it was a rude awakening that, no, just by limiting salt, you can't control blood pressure well. But
I read one article, and it was just one article, that said, you know, we've all debated about how important is this hypertension control issue, but that they looked at young men over a 10-year period of time, and they looked at a large group that had hypertension, and they took half of them and treated and watched them treated by an aggressive method, and the other they left to the vagaries of whoever they were following and their local doctor and so on and so forth. And half had significant higher blood pressure than this aggressively treated group, and there was a difference in their cognitive function. Not a lot of stroke difference in this young men, 10 years, but the cognitive function, their mental. Now, what is your response to that?
Well, I'm not familiar with that study per se. One of the difficulties in the Partners trial was a big, large prospective trial looking at patients with high blood pressure, and part of the analysis was looking at people like you and me, how well we did at managing patients with blood pressure, and the truth was we didn't do very well. More than half of those patients who we said, oh, we're managing them well, turned out that their blood pressure was not very good, either because they weren't compliant with their medications or we weren't responsive enough to them or pay enough attention to their blood pressure. We'd write it off and say, no, it's okay, it'll get better. You know, it's white coat hypertension. They come into the office.
You're all right.
So, yeah,
don't worry.
Right. So I think that...
what is your goal for systolic?
Well, you know, in many of my patients, I mean, I'd like to see their blood pressure in that 130 to 140 range. I have some specialized patients who've had aortic dissections or aortic disease where I'd really like their blood pressure to be, yeah, exactly. Yeah. That's exactly right.
But I have some patients who have 160 blood pressure, and I've treated them aggressively, and they come in with black eyes and and falls, and they will not take their medicine because they get really dizzy, and they know that their pressures drop, and they are labile. They have very variable blood pressures. And so I'm afraid that if I treat the 160, I'm going to get them down to 140. That one that is 160 down to 120, I'll get the 160 down to 120. Their 120, they'll also go down to 80.
Right. You know, of course, I remember as a medical student learning that systolic hypertension was not a bad thing.
It was the diastolic.
Right,
well, we changed our mind.
We changed our mind on that, and we learned that, in fact, those patients who were elderly and had a systolic blood pressure of 180, it was bad for them.
Yes.
I think one of the things is we're getting smarter about how to adjust medications. And some of that lability and some of that change in the orthostatic risk is, in fact, patients who, for example, allow themselves to get dehydrated, they're not drinking enough, or we put the elderly patient on aggressive diuretic therapy that may not be the best way to manage blood pressure. So
now, these are lessons we're talking to doctors, but you know, patients that are hearing this should realize that you got to depend on your doctor, but you got to tell them what's happening.
That's exactly right. Right. If every time they jump up to answer the telephone or the door, they get lightheaded and feel faint, they need to let their practitioner know and let them know that that's, and then they need to do a detailed, evaluation, determine are they drinking enough, when are they taking their medicine, should they take it in the evening rather than the morning, that sort of thing.
So we've got a bunch of questions we need to pile through quick.
All right.
All right. What are the symptoms of blood clots? Now that's it's a wide question, but how would you take that?
All right. So the most common blood clots are venous clots. They tend to be clots in the vein, and you've all heard about the traveler, the person who's on an airline flight and stuck in a chair, can't get up, is immobile. That's right. That you develop a blood clot in the vein, and the reason for that is that vein flow is low. It's low pressure. It doesn't, and so anytime blood is sitting still for a while, it will coagulate or congeal and it can form a clot. Immobility, surgical treatment for patients, long planar car rides, those are all predisposing factors.
Fractured bones.
Right. In most times, we can effectively treat that. We have many medications now, blood thinners, even for a short period of time, that are beneficial. What you don't want is that clot to get worse, to get a markedly swollen leg, or to have that clot go up to the lung and cause a pulmonary embolus. That can actually be a life-threatening event.
So real quick, do you have a preference over warfarin or the new drugs that are being advertised and are 3 times as expensive?
Right. So the 10A, the new Xarelto, Eliquis, some of these medications now, these 10A inhibitors, they clearly work very well. Many of them have shown decreased bleeding complications and very effective anticoagulation, and for venous disease, particularly Xarelto. The difficulty is expense, and for many patients, it's, you have to weigh the expense of that medication versus having your blood checked regularly and that sort of thing. I think to some extent it depends on, if you know that patient's going to be compliant and they're rigorous and they're, quite systematic about things, and they're going to have their blood checked, it's easy enough to maintain them on warfarin, which is pennies cheap. If in fact you worry about their compliance, there's someone who's on the run all the time or routinely doesn't come in for their blood checks, those patients, in fact, may be treated more safely with the medication that's a bit more expensive.
But I would argue that there is only one drug I really have except for anti-seizure drugs, that I really know that the efficacy of it, I can measure it, and that's warfarin. I mean, I can see how thin their blood is. And it's a drug that is so dangerous that too much will cause great problems. Non-compliance can cause great problems. And I'm happy that I can monitor them so very carefully. And so I do think there's places for these other new anticoagulants, but I'm not quite there for most of my patients. Is that a fair comment?
I think that's a fair comment. Many of us are very comfortable with warfarin and have been for a long time. And of course, I'm a Wisconsin alum. That's where it came from. The Wisconsin Area Research Foundation is where warfarin came from.
Yeah, and there's a good story there, but we'll go on. Madison, 62-year-old caller, has pain in the calves, varicose veins, feels the veins beating. Is this tachycardia or something else? The veins beating. That's interesting.
Yeah, so again, one picture may be worth 1,000 words here, but you know, certainly if he has significant varicose veins, he may very well be feeling increased venous hypertension, which is engorgement and bulging of those veins. Now, they're really not pulsatile, but they can certainly cause fatigue, heaviness, and it can really be uncomfortable.
Right.
The truth is that nowadays, again, we have some technology, but there's very little to beat elevation of the legs and the use of good support compressive stockings.
I wanted to hear you say that.
Right.
Good for you. 18 to 22 at least entire, not just the TED hose.
Right.
Real support hose or ACE wraps.
Right.
Discuss vasculitis, discoloration of the lower leg. Vasculitis, or maybe even that discoloration.
Okay, so the discoloration, we call that's a hemosiderin pigment. And anytime you have venous hypertension, patients with varicose veins or who have chronic swelling, they will, because of that, there's some fracture of the red blood cells. Remember, the red blood cells, it's iron that actually carries the oxygen. So as a result of that, that iron leaches out and stains it gets picked up by the phagocytes. That's exactly right. So you end up with that pigmentation. And that's a little different than a vasculitis. Vasculitis implies there's inflammation of the blood vessels. And there are giant cell arteritis, which is associated with polymyalgia rheumatica, you know, where these patients who get temporal arteritis. So there are some inflammatory conditions. They're relatively infrequent. We typically treat them with steroids. They're not something we operate on.
They're a tough scenario.
That's a whole different kind of thing. Right. Lupus, rheumatoid arthritis, all of those, that's right. Those are collagen vascular disorders.
Okay. Is there a benefit from taking omega-3? Do you know the data?
No, I really don't.
And I think that's it. There's not a lot of good data.
Yeah.
I mean, we know that people who eat fish get better or have less heart attacks.
Right.
And that study was pretty solid. We think it was the omega-3. Is it the fish oil? Or is it maybe eating more fish?
Right. And can you get enough of it? Now I think with some of the supplements, maybe you can, but
who knows?
I don't know.
Hole between the ventricles. Discuss how to fix.
Okay. So there are the most common defect between in the aorta, or I'm sorry, in the heart, is between the two atria, the upper chambers. And there's really two types. There's one that's called an atrial septal defect, which is a congenital defect that you're born with, and there's a couple of different types. And that allows blood to go from the left to the right. Ultimately, it overloads the right side of the heart, and those are generally, you want to close those. Now, it used to be we had to do it surgically. Nowadays, we have a device. We have a couple of devices that can be actually, they look like little plugs that you can put in there. You can put it through the vein, and in 30 minutes, you can be done with it. The other one that's common is a patent foramen ovale. We all have one, and typically they close at the time of birth or within the first 2 years of life. In cases where they don't, there's a risk that a blood clot from the right side could transfer over to the left and then go out and cause a stroke. And we see some of those. Those are typically the patients, young patient who has no risk factors, suddenly has a stroke out of the blue, and it turns out that they had this. They also can be closed now very effectively with these devices. Again, it's amazing. It's a 30-minute procedure, and it can be done, and you don't even have to put the patient to sleep anymore.
Fabulous new technology. Caller has a blood clot in her femoral artery and is on medication. Is she in danger of a stroke? Femoral artery blood clot.
Well, she's not in danger of a stroke, but she's clearly in danger of not having adequate blood flow to the leg. Again, blood flow is from top to bottom. It'll go down towards her feet. And in many cases, those can be repaired either surgically or with endovascular techniques to try and restore circulation to the leg.
All right, blood pressure diastolic is low, 117/67. Is it too low? Is there a danger in too low of a blood pressure if they're not on a blood pressure medicine?
No, generally not. The one exception to that is there are certain valvular heart conditions where where the aortic valve leaks and that pulse pressure changes so that because the blood flow flows back, and so as a result, the bottom number drops very quickly. So you see this increased pulse pressure between the systolic, which is the high number, and the diastolic, which is the low number. So there are a few conditions, but in general, that isn't enough of a discrepancy.
And that pulse pressure widens when you get older too, just because you're older.
Because the blood vessels are stiffer.
A little stiffer,
yeah.
Which is part of aging.
Right.
But if person's blood pressure is too low and they're on blood pressure medicines, I generally say you need less blood pressure medicine.
Right.
Get off medicine.
Right.
If you have an opportunity to get off pills, let's do it.
Right. Sometimes it's a matter of they take all their medicine in the morning and they need to spread it out through the day so that their pressures are low at one time and then it's high the other parts of the day. So I try and have people take a blood pressure diary to get a blood pressure cuff at home, and I advise all my patients to have that so that they can, because it's, they can check some things at home, and they can be really very insightful as to
what it's really doing.
Right, and helping us make a decision about what medicines they should be on and what perhaps they shouldn't be.
We've got 30 seconds. Hypertension for 30 years, treated with medication, has severe cramps in the legs. Could it be the medication causing the cramps?
Yes, it could be, although again, we need a little bit more information, honestly. I'm sorry.
I really think the treatment is stretch those legs before you go to bed at night and whenever it cramps. 10 seconds, so we'll be back right after this.
What would you do to save your child's life? Secondhand smoke can kill them any number of ways. So, would you stop smoking around them? Would you ask your family and friends not to smoke around them? Would you keep them away from places where people smoke? Of course you would, because you can choose. They can't. It takes courage to stand up for your child. But if you don't, who will?
Everyone wants to find a way to prevent aging. Let's face it, we will all grow old. Well, that is, unless we die early from a motor vehicle accident or cancer or an early stroke or heart attack. Of course, even if we took every precaution, one of these causes for early death might occur. But nowadays, don't we know how to prevent aging arteries, heart attacks, and strokes? Not surprisingly, in a response to the call to prevent early death, there has been an effort to just look and act younger in this country. The pharmaceutical industry has developed estrogen and testosterone replacement as well as Viagra to help sexual function, Botox and special creams to erase wrinkles, and even steroids and non-steroidals to treat arthritis. But what have we done to find ways to protect our aging blood vessels? In the 90s, researchers started blaming aging on excessive oxidation. And not long after, we heard advertisers talking about antioxidant effects, trying to sell this product or that supplement. We've been advised to eat this diet, buy that book, each holding the secret to a long, oxidant-free, healthy life. Unfortunately, we've learned that the main oxidative driver is simply too much food. And there's no pill for that. After scientific research, researchers found high cholesterol as a mild predictor for vascular disease. Many have been focusing on cholesterol-lowering medicines in an attempt to prevent aging arteries and atherosclerosis. Despite the fact that lowering cholesterol has been disappointing in prevention of vascular disease, sales for statins, the main cholesterol-lowering group of meds, have grown to be a $5.5 billion yearly business. All in all, these medicinal shortcuts to prevent vascular aging have too little effect and pale in comparison to the most powerful preventive treatment. Recently, the World Health Organization stated that 3/4 of all cardiovascular deaths and disease are connected to lifestyle. Say it another way, 3/4 of all cardiovascular deaths could be delayed by making lifestyle changes. We're talking use of tobacco, unhealthy diet habits, psychosocial stress, and most importantly, physical inactivity. Indeed, the real fountain of youth comes from lifestyle and not medicines. There are no shortcuts. The way to prevent premature aging is not by a pill, but by the way you live. This brings us to the end of our show this evening. I sincerely thank our good friend Dr. Mike Bacharach for helping answer our audience questions this evening. As often happens on the program, we weren't able to get to all your great questions. Please join us now on our website at oncalltelevision.com and click on the After Hours button to view our answers to some of the questions we didn't get to. Much of what we visited about tonight involves getting older. Writer and humorist P.J. Rourke recognized there's one more terrifying fact about old people. I'm going to be one soon. Until next time, stay healthy out there, people.
Funding for On-Call Television is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On-Call Television as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Dakota Care, Brookings Health System, Dakota Allergy and Asthma, Dakota Dermatology, Aberdeen Asthma and Allergy, the Orthopedic Institute, and Swiftel Communications. Closed captioning for on-call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.